So someone asked about IIH and its relationship to SIH. SIH is spontaneous intracranial hypotension. IIH is idiopathic intracranial hypertension. So in IIH, the ICP is high, but in SIH, the ICP is low. And the relationship between IIH, where it's too high, and SIH, where it's hypotension, too low, is sometimes it's so high, it erodes the bone and causes a CSF leak, and then it becomes low. So high pressure can erode through, and one of the places it can erode through, as you know, is the sella. So here's the sella turcica, and so they get an empty sella when they have increased intracranial pressure. And because this bone is relatively thin, it can erode right through the floor of the sella, and then you'll get a CSF leak. And that CSF leak, when it's coming out of your nose, is rhinorrhea, but it can also occur as otorrhea, clear CSF fluid coming out of your ear. The test for these fluids is the transferrin, beta-2 transferrin test. That's how we test if it's CSF or not. And so when we have a intracranial hypertension, it can present as SIH. It looks like a spontaneous intracranial hypotension, but really it was too high and then it became too low. And so we're going to use the MRI scan to try and help differentiate whether it's too high or too low. And as you know, the radiographic features of intracranial hypertension are empty sella, and in SIH, it's going to be a full sella. So the pituitary is going to be plump because it's got venous congestion in it. In IIH, we have venous sinus stenosis, but in SIH, we have venous sinus engorgement, and that leads to meningeal enhancement. So there's going to be post-contrast enhancement on the meninges. And in patients who have the IIH, they have a tortuous and dilated optic nerve sheath with fluid in the sheath. And in SIH, we probably don't see that. Both IIH and SIH can have similar presentations clinically. They both cause blurry vision. They can both cause diplopia from non-localizing sign of sixth nerve palsy, either high pressure or low pressure. But the differentiating feature between the two is the presence of the papilledema. So if you have papilledema, that's IIH. The only way I know, of course, is to do a lumbar puncture and measure the pressure. But to answer the question, definitely IIH can cause SIH. Too high can lead to too low, usually from erosion through the sella and a CSF leak producing rhinorrhea. And you can tell radiographically between the two, but really you have to measure the pressure.